midwives that they using these computer tablets, visiting to houses and then collected the data. So we actually we visited about 39,000 houses and then enumerated 120,000 population in Klinachi. Now that survey has started in Molativu, Mannar, and then Jaffna. Then next week it's going to start in Vaunia. And also the second phase starting in Klinachi in 2 weeks' time. So we got this first line, this all number of disabilities in Klinachi district out of this 120,000 population. But we don't know exactly how many disabled persons. After second phase only, then we can get the exact number. So now that for this disabled, after getting this data, we should develop these care facilities for these all disabled people. So then WHO, this new concept of palliative care, the palliative care concept earlier proposed for these cancer, the terminally ill patients, but now it's not. Things are changing, so we want to adopt that similar kind of concept to provide rehabilitation and palliative care. So the palliative care, even cardiovascular disease, cancer, all these chronic diseases, this palliative care is essential. So the palliative care is not for only the terminally ill, that all patients with chronic life-threatening diseases that we should be able to provide. There must be a comprehensive care. So then it should at home and then the community, then at the primary care level and the secondary level and the tertiary level. So already mentioned. So we would adopt this Kerala model of palliative care. That the palliative care started in mid-80s, around 85. Then they have the WHO Collaborative Center. There are 2 centers in Kerala, and then actually that their model, even this 85, they started to provide these post-traumatic paraplegic people and all these chronic diseases. Even this other world that the people were talking about this palliative care only for terminally ill patients. So their model is actually the training the volunteers to work in the community. So then volunteer driven, then the community organizations. The community organizations are linked up with this primary care, then the primary care is linked up with the specialty care. So same kind of model that the northern province, there are so many non-governmental organizations supported by this diaspora community. They're providing a lot of care, but it's not coordinated care. So the important point that we should coordinate, and also that these organizations, they need the training, the capacity building and the training. Then what happened in the Kerala that 80s, the mid-80s, they started as a kind of NGO-based and community, and later the state, the provincial government that took that ownership, and then they prepared this policy document. So similar kind of thing. Because of the time constraint, I'm skipping some of these things. So already there are community-based rehabilitation centers, one in Waihara, and then the hospice in Kane that supported by different non-governmental organizations, but with the partnership of the provincial government. So then in line, we are getting this rehabilitation specialty hospital in Mangalam, that's through this Thayalan grant, and also another rehabilitation, orthopedic rehabilitation center in teaching hospital, Jaffna. So we have identified this group for 5 priority areas to be discussed in the groups. So first thing is, I already mentioned that we are doing this disability survey, but unfortunately the disability survey we can detect already identified, but there are a lot of mental health disability, but people are not identified with the disability. So we need a special survey, but we can go for the community survey. So we are going to sample survey. Then the capacity building of these rehabilitation and disability institutions and the community organizations, and then functioning outpatient and institutional palliative care, and training program for community-based rehabilitation and the social supportive network. Thank you.
Thank you, Dr. Suren. And the purpose of these brief presentations are to give you a flavor of the issues so that when each of you are in your focused working group, you have an idea as to what the other groups are talking about, and then you'll hear back as to the next steps that have been agreed upon when we gather back as a group tomorrow. Next, we'll hear on human resource development from Mr. Krishna Kumar as well. You'll see. Great. Thanks.
Promoted to tech support.
Always. Hey, good morning, and thank you for having me here. My time doesn't start till, right, Krishna? Krishna, I still got, you haven't started the clock yet, right? No. So I think first of all to thank Dr. Sathyalingham and Dr. Lowe. I think we have covered a lot of the topics that I was going to cover, so maybe I can finish in 5 minutes. Let's see. Good. So first of all, thank you and good morning, and it's good to be around. And I mean, Krishna told me to set the tone for the this workshop or brainstorming session, and I thought I couldn't think of a better way than quote Eli Wiesel, Nobel laureate and Holocaust survivor. Now he said, the hungry children, the homeless refugees, not to respond to their plight, not to relieve their solitude by offering them a spark of hope, is to exile them from human memory. And in denying their humanity, we betray our own. I think we are here to give hope to the people back home, and I think this will set the tone for what we are here to do. So the area that I was given to talk is on human resources. I think I should give the credit to Dr. Katie Swerin, the Provincial Director of Health Services in Northern Province, and Krishna for putting most of the slides. I'm only the messenger, so they should take the credit for it. So this is a slide I borrowed from a WHO website. It very clearly shows what Dr. Lowe was highlighting: higher the density of the healthcare workers, higher the survival rate. It's a no-brainer, and that's why healthcare resources is such an important part of it. And it's not just the healthcare alone; it has a triple effect. Not only going to help improve the health of the people, but it also improves education and training, because we are recruiting these individuals and training them, and indirectly it improves academic empowerment. I think it acts in all three components of healthcare. So I think this is very important, maybe even more important than mental health, Dr. Sivayokan. So since Dr. Sivayokan was picking on one of his colleagues yesterday, I feel comfortable enough picking on him today. So in fact, they have renamed International Medical Health Organization as International Mental Health Organization. So hopefully that doesn't reflect the organization's board members. So this is the demography that was shown by Dr. Sathyalingham, so I'm going to skip it. Essentially, Northern Province, a population of 1.2 million with varying population densities, as Nanda stated earlier on, which comes with its own set of challenges. And Dr. Lowe also alluded to earlier on the challenges in a post-conflict area. There are, four of them are highlighted here: the widows, the disabled, the orphans, the elderly. And also the one for Sri Lanka, Dr. Sathyalingham highlighted, buried inside all of this are the ex-combatants. I think we look at them as a separate group in Sri Lanka for political reasons, but unfortunately they fall into these subcategories. And so I think it's a challenge that we have as trying to help build the human resources to keep this in the back of our mind. And the reason I'm going to briefly run through this is those of you who are not from Sri Lanka is a very well-developed healthcare system. Pre-war, it's a country that could match many of the developed nations for infant mortality, maternal mortality rates, and the education, the literacy rates. And unfortunately, 30 years of war has taken a toll. In addition to that, we had a tsunami in 2004, And that, unfortunately, 2/3 of the people died in tsunami are women and children. Because men were strong enough to hold on to the trees and whatever they could hang on to, so the waves did not pull them back. Or a lot of the men were at sea working in the morning hours. So I think with war for 30 years and tsunami, what has led to is a disproportionate number of gender imbalance and a smaller group of young, vibrant men and women who could contribute to the society. So the burdens at the two extremes, and I think as diaspora we have a huge role to play here. I think this is something that we need to talk about in our discussion groups. But as you can see, the healthcare system in Sri Lanka is divided into curative and preventive sectors. And as you can see, there are 233 preventive care institutions and there are over 105 curative. For that, look at the number of the consultants in the house office. I think it's mind-boggling. It's I mean, compared to the Western numbers for such a large number of institutions, how there's a significant shortage of staff. And the greatest one I want you to see is the one on the third row, nursing officers. Look at the ratio of the nursing officers to the house officers, almost 1-to-1. And this is even sad. It says it's approved cadre. This is what accepted by the central ministry or the local norms. But as we know, if you have to provide healthcare, this ratio doesn't make sense for any healthcare provider. So I think that shows the importance of need to have our own data that Dr. Lowe has alluded to earlier on. This is again, I think, going through the same stuff. I think we have been through, this shows the number of visits, almost about 3.5 million outpatient visits and about 500,000 now, 400,000 of inpatient visits. This low number of physicians are taken care of. And the statistics are even more staggering, like Dr. Muruganathan shows for East, as a larger population with less workforce. Right? That's, they can only imagine how worse it is. I think the reason I put this slide up, I think Dr. Satyalingam also had it on. I think for all of us in this room to realize, in the local media you may have seen there are millions of rupees in Sri Lanka. What's going on with the people? What are they doing with this? How come they can't invest on various stuff? As you can see, almost 86% of the budget goes to sustaining the existing projects, paying salaries. Only there's a very, very, very small amount of funds left for capital expenses. And within capital expense, you have to keep in mind, some of them are flow over from the previous year, the capital expense is not done, so some part of the capital funds goes into the existing capital funds expenditure. So there's a very small amount of money left for new projects. Great. And these are some of the root causes for crisis in the Northern Province that we're going to highlight. We'll be talking about at least, you know, all of you should be familiar with it. And I think that I want to probably bring my talk to an end. You know, I'm a big guy, a believer of all these quotes that it energizes me and empowers me. And this is another Nobel Prize-winning Chilean poet who wrote this. Now, many things we need can wait, the child cannot. Now is the time, his bones are being formed, blood is being made, his mind is being developed. To him, we cannot say tomorrow. His name is today. So hopefully, ladies and gentlemen, I think we have enough number of people in this room who are interested and passionate and committed to helping the people in Sri Lanka. And this is, I'm going to end my talk with what Margaret Mead said, you know, never doubt that a small group of committed, thoughtful citizens can change the world. Indeed, it is the only thing that ever has. And I hope we have enough of those committed citizens here this morning to make a difference, start that path. Thank you.
Thank you so much, Dr. Thavam, for walking us through the human resources issues and also providing some inspiring quotes at the beginning and the end. One contextual piece I'll provide for the non-Sri Lankans in the audience is that the human resource needs, as you've seen, are great in the north and the east. One of the key things that's necessary, which they'll probably report back, is prior to the northern province or the eastern province being able to hire additional staff or actually create new cadres of staff that may be necessary. They need to negotiate with the Central Ministry of Health and also with the Treasury in Colombo to ensure that they are comfortable and approve the allocations of funding, not only for a single year, but on an ongoing basis. And so that's a consideration to keep in mind. Next we'll hear on health informatics from, I believe, Mr. Suthan from the Northern province as well. One thing to note, if anybody's recording this, it should just be for personal use and not for distribution, unless you check with us.
Good morning, everybody. Thavam. Actually, I am going to cover the informatics. We have the problem. We are having the information on the paper based, but world is going fast. We are unable to take the real time decision on the health situation. So we need to focus. We have to work with the international community, international level to bring our health information. Then only we can have a real-time decision to take the action. So when you see this situation now, the real-time information is not available. Take the decision. Because the politicians, they don't have the information. The provincial directors, they don't have the information. We have to wait until 1 or 2 months. Even we have presented this all information, the data 2014 and 2015 information. But we need the real time information to support our community on. Particularly, we can see what are the added value if you have the real time information. The system, the healthcare provisional, we can have a real-time information. In meantime, the universities, particularly from the outside, they can come to the research. When you have the last 15 years here, most of the information they have, most of the money is spent for get the primary data. So if we have the real-time information, we can have a added value to take the decision. So according to our priorities, we have selected 7 areas to speed up our attention to bring the database system. The electronic database system particularly help to different level, because we have electronic child health network. We have the babies. If the vaccination program is designed by the central government, it's implementing in the hospital level, it's not coming to the ground level. The emerge and even we have the 2 level. One is that from birth until secondary education, we have the health program. Even after the grade 1, 4, 7, they have the number of health programs, particularly focusing the issues, particularly the malnutrition issues, focusing the END and other issues. They have to have the whole information in the paper. Almost 18 forms they are filled by the PHI, PHM in the different level. So if you introduce that electronic child health network, like starting from the birth until school level, then we have the comprehensive information about the diseases. Where, which location, which school they have the more children problem. What are the problems? Then we can easily give the solution to the people, particularly for the resource mobilization. We can mobilize the resources. And food safety management information, like we have now only redeveloping our nation. There are a number of food processing industries are coming up, food outlets are there, but all the PHA are monitoring the standard, they are maintaining the standard through the paper based. So once establish the electronic data, then the PHI are empowered to monitor the system. They can go to the site, they get to the processing center, then they can make it the international standard. Then only we can bring the tourism to our nation, then tourism will give more economic for our nation. And the telemedicine. Telemedicine is, according to our statistic, 24 peripheral hospitals functioning without the medical officers. So we hired with the external support pre-interned medical student to manage the hospital. So if introduce the telemedicine in this hospital, we can easily address the patient issues, particularly they don't want to spend their time. They don't want to spend their traveling cost to come to the main hospital. And also we have very shortage of specialists. So we can link with the main hospital, particularly the major general hospitals, then easily link with the remote hospital through the telemedicine advanced medical system. And also we have developed two web portals. One web portal is under the Northern Provincial Council. Just they are giving the information on the events. It's not helping to the public get ideas, user-friendly information, which hospital, what are the facilities are available, who are the clinic schedule, there's no any information. So it will help this help portal definitely to give the information public, because everyone are using the high-tech technology, particularly everyone have the Facebook, everyone are using the social media. Once it's introduced this system, our young generation will pick up, get this access. Particularly when you look into the northern province, around 90-95% of public using the public hospital rather than the private hospital. So it's very helpful to the public to go and get the services. And hospital health information, then another website we are talking, I think our minister pointed out that we need to interact with the international community, with local experts, to bring all the resources to address the issues. Only one, the ministry, according to our budget, the national budget, we can't sort out the problem. So if you bring all the experts from the different level, they can contribute to develop our nation. So that is the objective. We have developed this portal. Definitely, probably from next month, we have more interaction after this conference. We can have a good output. And the hospital health information management is the WHO is the concept we have started in 2005 in Sri Lanka. Then the government take up introduce the health hospital health information management system each hospital. According to the government plan, they are targeting only 300 hospitals. It's up to hospital the level until B level. The divisional hospital is not allocated. So then divisional hospital definitely addressed by the Northern Provincial Council. They clearly told that. So we need the external support particularly from the diaspora to introduce the hospital-based management system. And another one is the centralized electronic person administration. It's a help. We are most of the time we are spending to get the demographic data. So we need centralized database in the Northern Provincial Council. It should be located in the Northern Provincial Council. Then each information, the demographic information, transferred to the different areas like education or health or livelihood, whatever area they can transfer those information. Then there are other priorities identified our working group, trauma registry, mental health registry, database for indigenous medicine data. These are the areas they have requested. So we can integrate all the requirements with the main database. Okay, what are the expected support from the diaspora? We want to establish the international working group here to develop the IT infrastructure in the northern province. So international level, they have the working group. In the ground level, we have the working group. Then we can exchange the idea. And also we need some international standard. I think we can discuss more in our working group discussion. This is our budget, but I don't know whether it's convenient, but we can simply sort out this problem. Thank you.
Thank you for that information and the quotes to end with as well. As you've seen, there's many different databases and surveys that are in progress, and one of the things that the working group is going to be focused on is to ensure that any new surveys, any new databases are structured so that they can be integrated in an efficient and cost-effective way. Next, Dr. Ambalavanar will speak about injury prevention and emergency care.
Okay, good morning to everybody. I'm Dr. Ambalavanar. I'm a surgeon based in Jaffna, attached to the Faculty of Medicine there. First of all, I must express my gratitude to the organizers of this conference for this, and it's a wonderful opportunity for all of us to work together to improve the situation back home. So I'm just going to try and give a quick overview on this topic, which is injury prevention and emergency care. Young colleague of mine, Dr. Puviharan, will give a more detailed presentation in the working group. So this is, trauma is a pretty serious challenge in the northern province. As Dr. Lowe pointed out, I mean, earlier on, of course, most injuries in the north were related to the conflict, which thankfully has not been the case after 2009. I can remember as a surgeon working there in the 90s and so on, a lot of the injuries were landmine injuries, shrapnel, bullet wounds, and so on. So it's, as a surgeon, one almost feels happier dealing with the other kinds of trauma which you see everywhere in the world. So road traffic accidents are one of the serious causes. And it's interesting that in our province in the north, unlike in the rest of the country, morbidity and mortality from road traffic accidents has actually been increasing, whereas in other provinces it's been on the downward trend. And just from the Jaffna district in 2013, about 17,000 injuries, patients with injuries who came in. However, this is not a full picture, and again it comes back to data analysis, because we really don't, road traffic accidents are recorded as such. However, we don't know how many other injuries are due to occupationally related, how many may be due to assault, how many related to home accidents, domestic violence. So we really need to get this data. And for that, as Suthan mentioned, we really need a trauma registry, and that is one of our priority needs in this area. A colleague of mine, Dr. Govi Shankar, is the orthopedic surgeon in Jaffna. This is very much a pet project of his. And he's been dealing already with people like Promotion here, Silicon Valley. So they've drawn up some plans, and we hope that we can get some funding to get this established. So pre-hospital care, as the minister mentioned, and I'm happy to see some people from the paramedic services who are in the audience. So welcome, and I look forward to working with you all later. Sri Lanka, despite, as Thavam said, we can take pride in a health service which is otherwise quite good, considering we are a developing country. But for some reason, pre-hospital care is non-existent. And I may be letting the side down by saying this, but part of it is unfortunately related to the possessiveness of certain healthcare professionals to not have competition, and therefore we have a very strong nurses union, we have a very powerful doctors union, and they don't like the creation of new healthcare professionals. So a paramedic cadre is non-existent in Sri Lanka. So very commendable to Dr. Satyalingam and the Provincial Director of Health Services for the Northern Province, Dr. Suren, because our province was the first to have a free call-up ambulance service from January 2016. So anybody in the north, if they need an ambulance to get to hospital for an emergency, can dial up or call a call center and get an ambulance. But unfortunately, it is still at the moment just a glorified taxi service. Certainly far more comfortable going on a stretcher than in a three-wheeler or a bus. But unfortunately, it is that because we do not as yet have sufficiently adequately trained staff to man these. So one of our major requirements is training of ambulance crews. As was mentioned earlier, we did work with qualified paramedic instructors from the London Ambulance Service who came to Jaffna last year, and they trained 12 of our medical officers as trainers, and they've been conducting training. Unfortunately, our ambulance crews are basically just school leaving qualified, O-level or less. So they have no medical background, no training, and therefore these friends from the London Ambulance Service helped design a program, a 5-day first responder course, which we have been imparting to them. So one is we need to continue training them to an adequate level of competency, and the other is we need funding for training equipment, basically things like mannequins, orthopedic scoops, spinal boards, stuff like that, for which we now scrounge from place to place to get together just to conduct a training, which is not really a practical thing in the long term. So these two areas, in terms of training and funding for equipment, is one thing where our diaspora can be of great help to us, and we hope to develop those ideas further during the working group discussions. So emergency care, the challenges are, again, no hospital in the north actually has a proper accident and emergency department. Now the central government is now in the process of developing these. Even the teaching hospital where I work, we don't have any A&E department, which is a great embarrassment for us. But that is now slowly being changed. So we also need to have our healthcare workers have up-to-date skills. Basic life support, advanced life support, trauma training is not something that's done regularly for medical officers and nursing officers. Again, this is an area where the diaspora can play a very useful and important role. Injury prevention, you may think that should have been first slide. The reason why it's here is just an overview. It is an important area. We need to work with the Education Ministry, with the Police Department, and so on. But in terms of training material, awareness material, the diaspora can provide funds. Krishan has been holding up fingers, so I'll try to go through the rest quickly. So these are the budget for special needs, not as much as the IT people asked for, so I hope we might be able to get this. And so those are our needs. And just so that Thavam doesn't get a monopoly on quotations, I'll just end with this. Coming together is the beginning, keeping together is progress, working together is success, and we look forward to that. Thank you.
Thank you, Doctor, and for the quotations as well. As you may have realized, the Tamils are a poetic people, and so that's one of the reasons why that's peppered through the presentation. One piece just to stress in terms of the importance of emergency care, again, for the non-Sri Lankans. I was just there, and you'd be amazed. We're a small island, and between Trinco and Colombo might be 6 hours, but people will think nothing. Dr. Prem went down from Trinco to Colombo to deliver papers in person, and it's a small island. I tell people it's not that small, but we pretend like it is small, and we, for our major highways there, single carriage, so you have a vehicle going in one direction, all the other vehicles are coming the other direction, and to overtake, they have to go into the other lane. And that's the way we go from place to place. And to put that context the 193 deaths into perspective, I'm assuming a 75-year life expectancy, the actual chance of dying is during your lifetime in a road accident is roughly 0.65%, which is extremely high. So just to stress the importance of that piece. Next on mental health issues, we'll hear from Dr. Sivayokan, and then we'll break into the subgroups.
Thank you. Where to start? I think the whole theme this morning is with better health we can have better development, including economic development. And mental health is one of the components of health, not the sole component. The context there in our place is that I have listed out a little bit. Even though we didn't have a first-class study, but whatever the studies available, I have collected the data. So around 10 to 25% of the people they are having mental health problems, and among them, in total about 2 to 3% have serious mental health problems. So that's a case load as doctors that we have to look into. And the other study says that most of the people who are attending to outpatient departments are having some form of mental health problem, but because of the stigma, they don't want to claim it as a mental health problem and try to present it various unexplained medical symptoms or the somatization symptoms, and then overloading the health resources. So that's another issue. People are in a post-conflict setting are very fond of this PTSD diagnosis. In a way, it's good. It has some numbers too, but our experience is that the PTSD is there in the community. But when you look at the hospital data, then you get very little amount of PTSD. Once again, people who have been traumatized and experiencing their traumatic experiences are not coming to the hospitals, to the mental health units because of the stigma. So the population studies, even a study done in 2010, then they showed about 14% of them are having PTSD. But our way of understanding the trauma is that the trauma is now, it's not an individualized kind of trauma alone. So trauma has gone beyond the individual in a more familial level or more community level. So all the people are somehow being affected by these traumatic experiences and behaving as a result of these accumulated traumatic experiences. The one-time survival value of war is still continuing. So we find it difficult to move towards a developmental sort of mindset. So partly because of this collective trauma accredited process. Somasundram. Suicide rate is on the increase in Jaffna. Sri Lanka as a nation, suicide rate is slowly declining, but Jaffna and Northern Province as a region, that regional suicide rate is on the increase due to various psychosocial stresses people encounter. And of course, anywhere in the world, you get more attempted suicide when the suicide rate is increased. Alcohol and substance-related problems are very high nowadays. For the first time, we are seeing more and more young people with substance abuse, cannabis, heroin, and various other substances. Of course, the effect of this trauma is now can be seen in various violences against vulnerable groups, women, children, and so on. huge number of child abuses, sexual abuses are going on. I don't know how to explain that phenomenon, why people are behaving like that, but it's happening. And of course, for good or bad, divorce rate also is increasing, and the ever-increasing psychosocial stresses. This is a context that we deliver mental health services, not only to deliver services for the 2 to 3% of the seriously mentally ill people. This slide I borrowed from Professor Somasundaram. He did a community survey, household kind of survey, not a very there was no sample, but there was a community program, so the community workers visited house by house and collected this data, and then pictorially, then we were able to present this. So you can see the wide variety of mental health problems. So it's not having a hospital and having 1 or 2 doctors and 3 nurses to deliver the services. We need to think slightly differently to address the wide range of mental health issues. Having said that, just to give you some numbers, this is the data for the northern province alone in 2015. So there were 2,000 odd people were managed in a hospital settings as inpatients. There were some 82,000 people who come and go as an outpatients. So similarly, all the data are there. You can see. Probably I can say the attempted suicides alone about 1,500 and so on. So why I am putting this data so that I can compare this figure with the human rights situation that we are having. The whole northern province, we have only 3 psychiatrists and 4 diploma holders. We were able to produce an in-between sort of people and 10 medical officers. Fairly okay, but probably we can have some more doctors. But look at the other figure, the nursing officer. We have only 24 nursing officers to cater for these 2,341 admissions on around the clock in 4 different inpatient units. So it's very, very difficult to deliver a basic sort of services there. Few cadres are not at all existing cadres in mental health, like psychiatric social workers, occupational therapists are non-existing. We do not have a single psychologist in the region. So as an alternative, we developed some in-between people and asked them to work as counselors. Some are working with the health department, some are we are borrowing them from non-governmental organizations and so on. But with the great initiative of our minister, we were able to produce the last level card. We now have 45 full-time workers to work in a community level for mental health. So that's something I have to congratulate Dr. Nathilinga. It was his initiative, understanding our issues. So we were able to create that card. A small comparison, I'm sorry. Yeah, my mother told me not to compare yourself with others, but unfortunately, the last row. Look at the Norway and look at the northern province, and especially the nursing profession. I think other than the last row, we borrowed this information from WHO. A huge disparity, and we are unable to sort of provide the services. Demand is, on the other hand, is on increase because of fairly good awareness among the people. Stigma is still there, but slowly it's declining, and people now can see that people are sort of recovering from mental health and they can function. So as a result of it, we get more and more clients now. The other challenges, these clients are now demanding for non-medical approaches. It's not the clients, even the conditions demand for non-medical approaches. We can't prescribe pills to each and every condition. So we need counselors, we need family therapy, we need to sit with them, we need to train them on relaxation therapy, we need to go for a group of people for cognitive behavior therapy, social case work, legal work. Who are there to do it? So this demand is very high. And there's also the demand of these various subspecialties, child psychiatry, forensic psychiatry, family therapy, sexual problems also to large extent they are coming to us because most of them is psychological in origin, and the disability. I think to cope with the demand, probably we have to find some ways. Unfortunately, mental health is not still not there in the priority basket. So that's something, it's very worrying. People are talking about mental health and psychosocial well-being, But when you approach them, especially the managers and the policymakers and the decision makers, it's very difficult to convince their mindset, apart from the traditional maternal and child health sort of, because those are the indicators or the indices the country is proud of, so they don't want to look at the other side of health. So 3 needs, I'm going to discuss that in our group. One is human resource, how to improve the human resource scenario. There are few infrastructures badly needed at this juncture. I have had some discussion with Dr. Ambalavanar, my counterpart, who is working in Battigala Hospital, consultant psychiatrist. And we also want to sort of discuss about some various soft components, how to improve the team effort and capacity building and governance related issues and so on. So those are the things probably we can discuss that in our group work. We have some funds and yes, thank you. I'm sorry I do not have a quote to.
Thank you so much, Dr. Sivayokan. Now we're going to break into the groups. A few points before we break into the groups. For the moderators, I encourage you again to try to be relatively strict on the time in terms of the presentations and the questions and answers, so that you have sufficient time to have clear next steps with responsible parties and the timeline also, and also the sense of how many people can be served in the north and the east if those next steps are executed upon. Just to give you a sense, in this room and outside, there's about 100 people who will be in these working groups for the next 5 hours. So that's 500 person hours. And I just want to stress, unless we have clear next steps with responsible parties and timeline, people's lives in the north and the east won't improve. So I encourage you all really to focus on that. Second, there should be 2 note takers in each group. One is a volunteer, and the second one I would ask for one of the observers in the room to actually help as well. So there's 2 sets of notes and they can work together on that. Third, just a reminder in terms of the rooms, for HR development, that's in the boardroom near the washroom. So you go out here, you walk down, and it's a room called private dining room, but there's a little sign there that says that that's for HR development. Health informatics and disability will stay in this room, split up side by side. Mental health will be in the south room, which is near the elevator down there. Emergency care will also be near the elevator in a room called north. And if you just walk down there, there's a sign there as well. So now we'll break out into the groups. Lunch will be outside at 12:30. Groups can work during lunch, or you can take a break. From a public health perspective, I would encourage people to take at least a 20-minute break for lunch. So I encourage you to do that as well. Then you go back into your groups, you keep going until about 5 or 5:30. We'll regroup here tomorrow at 8:45 to do a brief recap of day 1, give you an outline of day 2, and then we'll go into thematic groups for the Eastern Province, and then we'll spend the rest of the day tomorrow, most of the second day, finalizing next steps, and we'll have a brief close on economic development as well at the end of the day tomorrow. So I'll pause before we break out. Any questions on logistics and other details? Sure, great, thank you. So disability will stay on that side of the room, and health informatics on that side of the room.
Do we come back to do a presentation or discussion at the end of the day today?
Tomorrow, actually, tomorrow. So everybody, the outcome from your working group should be a summary of what you discussed, and also a table of next steps with responsible parties and timeline as well, which you'll give a presentation back to the group, roughly about 15 minutes per group. Any other questions? Seeing none, have a productive morning and afternoon, and we'll see you during the course of the day. Thank you.